Hi and welcome to another video from the CTAD Clinic. My name's Dr. Mike Lloyd. In the video today I'm going to be looking at what's known as Other Specified Dissociative Disorder, also known as OSDD, but in a very sort of particular way. Because one of the things that I've noticed and that gets discussed quite a lot in various forums and sort of online groups and things like that is a differentiation between OSDD-1a and OSDD-1b. And people spend a lot of time really trying to sort of organise and trying to work out what's what and thinking about the diagnostic criteria of OSDD into those two separate groups. So to start with, it's just worth having a look at exactly what we mean by the 1A and the 1B. And in very general terms, it often comes down to distinctness of alters and presence of amnesia. So dissociative amnesia is generally present in many dissociative conditions, and the experience of dissociation is often very amnesic. So OSDD-1a is thought of in terms of quite high levels of amnesia. Amnesia is often present, and then the type of alters that are present within the internal system are often much more indistinct. So they're a little bit more variable, a little bit more vague, not quite so highly organised or compartmentalised. When we think about that, it's more about looking at the nature of separateness from the person or the main self state. So they're often a little bit more sort of general. The borders and boundaries between the states are a little bit less well defined. And in OSDD-1b, it's quite different in that there's often much less amnesia present, or the amnesia is more variable in terms of the general experience of self. And the parts have a sort of a greater degree of sort of individual unique qualities, that the more separate qualities that brings us more in line with thinking about stuff like DID, Dissociative Identity Disorder. But ultimately, and this is where I think some of the difficulty sits, is that clinically it doesn't really make a lot of difference to the nature of the treatment that we're offering, because on a clinical basis, when we diagnose OSDD, we think in terms of what is the severity, in terms of the intensity, the frequency, the nature of the actual experience of the person, rather than differentiating the state between 1A and 1B. So when we're making the diagnosis, certainly in terms of our clinical process, we don't diagnose OSDD as 1A or 1B, we just diagnose OSDD as the diagnostic criteria. We then think in terms of treatment around intensity, severity, and the quality of the experience in terms of things like communication, collaboration, organisation, the degree of influence, the timing of it, all of those different variables which look at actually whether the OSDD is kind of dysfunctional or functional in terms of just managing everyday life. And what we notice with OSDD specifically is that there is a really important treatment trajectory that takes place during the course of therapy. So we begin therapy, OSDD is usually kind of chaotic, it's a bit ill-defined, it's a bit unsubstantial, and there's often loads of amnesia present. So we'd often almost say, like in the stability phase of treatment, OSDD is more like in a 1A position, but as treatment progresses and the amnesia starts reducing, because that's part of the treatment that we're looking at organising, the alters tend to become a little bit more present in terms of their communication tends to be clearer, better, more defined. They might have more confidence, trust coming forward. The nature of the influence might become more verbal rather than sort of in an emotionally driven way. And then we by the time we get towards, say, trauma processing, the OSDD would look more like a 1B type system or setup. So in that case, clinically, we don't really think, oh, you started as 1A, we would change the diagnosis to 1B. We would just see it as being OSDD that at the start is like really sort of, say, unstable, chaotic, disorganized, not very helpful, not very sort of, collaborative in terms of either the process for the individual or for the therapy. And by the time we get towards the midpoint of our treatment plan, the OSDD should be much more defined, much more organized, much more communicative, and we're able to negotiate, deal with and organize everyday life within that system. So it would be that more 1B type thing. So we don't really think in terms of 1A versus 1B. It's often like more severe into less severe. And then obviously we continue doing the therapeutic work as best. So I get asked quite a lot on the channel, like, would this be considered to be 1A, or what's the differential criteria for 1A, 1B? And often I sort of shrug my shoulders and go, it doesn't really matter on a clinical perspective. I totally understand why it matters on an individual basis, because people really like the detail and to have it correctly, stated exactly what their experience is. but realistically we don't approach it like that within clinical settings. So it's a theoretical construct rather than a clinically useful construct in that respect. So I'm totally fine for people to think about themselves obviously with 1A or 1B in terms of their dissociation, their OSDD. It's just that it's not something that features really heavily in the clinical room when we're actually providing the therapy. So I hope that kind of answers many of the questions that we get. I thought it would be a useful time to really sort of put that out there and just offer my thoughts on this. Again, really useful to hear what people say in the comment section, and yeah, because I know that this is something that's a really important topic for lots of people, and I'm just trying to approach it in a way which really sort of shares the approach between the difference between the patient experience and the therapist experience of conditions of this nature. So I hope this has been a helpful video. Again, yeah, love to read the comments. Please do all the like, subscribing, and in between now and the next video, as always, please do take great care.